time after transplantation. The genus of Aspergillus involved this patient. It has many species, but the most important is Aspergillus fumigatus. Aspergillus fumigatus after Aspergillus flavus. Aspergillus niger, clavatus, nidulans, niveus, and the other one. But first, Aspergillus fumigatus is pathogen, more pathogen compared to the other, and after that, Aspergillus flavus. You can find this fungi, this fungus element in air and respiratory system involved at first because it is airborne disease. Airborne disease. Inspiration the air may have a spore of this fungi. It needs some predisposing factor, for example, hospitalization, about solid transplantation, liver, kidney, bone marrow. And some the other condition, for example, neutropenia, but it is very important. You can find this infection in diabetes. Aspergillosis has three shapes of clinical sign. One and important and common is pulmonary aspergillosis. Pulmonary aspergillosis. Another, nasoorbital aspergillosis and disseminated aspergillosis, systemic aspergillosis. Usually you find patient with pulmonary aspergillosis. Pulmonary aspergillosis may show allergic form, sensitivity to allergen spore and material of this fungi. Allergic form include asthma, allergic alveolitis. You must check, you must study for this word, alveolitis. Do you know alveolitis? No? Yes? All? You must check and find the definition of alveolitis. ABPA. Aspergillosis. It's okay. Allergic bronchopulmonary aspergillosis. It is well known in mycology as an allergic form. Pulmonary aspergillosis, one form is allergic form. Asthma, ABPA, and alveolitis, allergic alveolitis. We have two types of infection without allergic form or except allergic form. Invasive aspergillosis, non-invasive aspergillosis. Invasive aspergillosis means localize and limit infection in lung. The spore entrance via the trachea and localize in lung. Grows and produce a mass in lung. The mass name is fungus ball or aspergilloma. Fungus ball or aspergilloma is a localized and limit colonization of fungi in lung, in respiratory system. May you have single Aspergilloma or multiple based on the expiration of spore, the amount of spore that you uh, insert in your lung. Aspergilloma is a fungus ball. Aspergilloma is fungus ball. Fungus ball means growth of Aspergillus in lung. It is three-dimensional growth and it is a colonized or colonization of Aspergillus in lung that colonize in a heel lung scar or abscess from a previous disease like as tuberculosis. This is a form of localized or non-invasive aspergillosis, non-invasive of that show fungus ball and aspergilloma. You can find fungus ball with radiography. Another form of pulmonary aspergillosis is invasive aspergillosis. Non-invasive means limit and local, but invasive means spread, yes, spread in lung or via the blood vessel to another organ. Invasive aspergillosis can occur as an infection with pneumonia, lead to pneumonia, pneumonia, lung infection that spread to heart and via the circulation go to brain, go to kidney, via the bloodstream. A non-invasive is very dangerous and lead to death, the patient. For detection, the which are invasive, yes, invasive because it is a systemic dissemination form of infection. Uh, one of localized and uh, limit form of aspergillosis is nasoorbital aspergillosis. In nasoorbital aspergillosis, you can find at first in paranasal sinus infection, paranasal in nose. The first location of infection is sinus, paranasal sinus. Spore go to paranasal sinus, nasal sinus, and start to growth, especially in diabetes, especially in a patient with immunocompromised treatment, immunodeficiency, suppression, immunosuppression. Yes, yes. The drug is cortisone, but in generally we use immunosuppression. When you want depress the immune system, you use corticosteroid. This means immunodepression. But in HIV, we have immunodeficiency. It is different. In compromise, compromise at the end stage of immunodeficiency or immunosuppression. A low immune activity, low depression. Cancer? No, no. We don't have usually in leukemia. In after treatment after treatment. In some hemological disease, for example, cancer, usually find mucormycosis in next file. We explain mucormycosis. Mucormycosis is important in hemological disorder like as cancer. Okay, in nasoorbital, at first the spore enter to nasal sinus and start to necrose, start to inflammation in nose and go to eye, eye, nasoorbit. Orbit mean orbital, eye. The infection spread from nose to orbit to eye, and after it can go to brain via optic nerve. It is occurred in Aspergillus, but it is very important in mucormycosis. In next file, mucormycosis. I will explain it. Anyway, we have nasoorbital form of this infection that may lead to blindness and brain infection in some patients. In form of disseminated, really we have invasive aspergillosis, or in some patient with weakness, with immunodeficiency condition, the spore enter to lung and via the circulation spread to brain, spread to the other liver and the other part of body. The disseminated form is dangerous. The invasive form is dangerous and may miss the patient. Sometimes you may find a skin lesion in Aspergillus. Usually in burning, skin burning. Usually the spore lie to lesion and the physician generally treatment burning by antibiotic. In long-term antibiotic therapy, you find a fungal infection. One of them is aspergillosis. Sometimes aspergillosis involve skin as a secondary fungal infection in burning. Sometimes the infection is secondary via the systemic form. Sometimes we have secondary skin lesion after systemic form of aspergillosis. The aspergillosis need laboratory diagnosis. Really and generally and usually, diagnosis of diagnosis of mycosis, diagnosis of mycotic infection need to laboratory. We cannot diagnose the infection without laboratory report. Aspergillus, like as the other infection, the other mycotic infection, need to laboratory examination. In laboratory examination, based on the place of infection, sputum in lung infection, BAL in lung infection, and biopsy of skin, biopsy of sinus, paranasal sinus, You must prepare and check it with direct examination and culture. In aspergillosis, direct examination uh, is the standard and golden standard way for diagnosis. Direct examination. You must in you must find mycelium in a specimen. Septate mycelium. At first class, I described we have two mycelium, septate, non-septate. In aspergillosis, if you find septate mycelium, diagnosis is aspergillosis until 99% probability. 99. And that complete to 100% with culture and isolate the aspergillus. Uh, if you find septate branching or non-branching of mycelium, sometimes it show uh, dichotomous, dichotomous septate branching, dichotomous branching with uh, two a mycelium with two branch mid dichotomous. It is not very important, but septate mycelium is important. Septate mycelia. It is very important because we must detect from mucormycosis. With direct examination, you find aspergillosis, and for complete diagnosis, you must culture the material on media, suboromedium, and cross the colony and check the colony for aspergillus. The diagnosis is complete now. Today, today there are many additional way and helpful way for diagnosis of aspergillosis of systemic mycosis. One of them is determine the biomarker metabolite, biomarker antigen. For example, beta tubulin, galactomannan. This biomarker is helpful test for complete the diagnosis. But the standard way is direct microscopic examination, complete with culture. You have clinical sign, direct examination, and culture. A complete diagnosis of aspergillosis. It is a microscopic aspect of aspergillus. The treatment the treatment made by amphotericin B and second with azole. Now voriconazole. Voriconazole is better than the other azole in aspergillosis treatment. At first, we start with voriconazole, and if we have any response, we change the antifungal drug, amphotericin B, or the other also. No, maybe in about nasoorbital form. You need surgery for empty the necrotic tissue, or sometimes when you have eye involvement, may you empty the eye. But generally, in systemic mycosis, there isn't any surgery. You must uh, treatment with drug. Summary: invasive aspergillosis is caused by filamentous of fungi. The genus is Aspergillus. Inhalation, the main way inhalation, inspiration of conidia or spore usually affects immunocompromised patient, immunodeficiency, immunosufficiency, immunosuppression. The patient sensitive to acute this infection. The clinical findings are non-specific. We haven't diagnosed a lung infection is with clinical sign it aspergillosis. Only radiography show fungus ball. Lung, sinus, brain, skin are site of involvement. Voriconazole in the antifungal agent is as a choice, right? Okay. Are you tired or continue? Tired? We have any time. It is the last time. We must finish it. Finish?